Good morning. You're watching the morning show here on Arise News. I'm Biola Labi.
Good morning. I am Veronica Deca.
Good morning. I'm Tundra Biola.
Security of lives and property of the citizens is a fundamental responsibility of any government. How safe do Nigerians feel as they prepare to go to the polls in 2019? That is what we will be focusing on after this short video on the rising spats of insecurity in Nigeria.
World AIDS Day is held on December the 1st each year and is an opportunity for people worldwide to unite in the fight against HIV, show their support for people living with HIV, and to commemorate people who have died. Despite recent improvements in treatment, the AIDS epidemic still claims an estimated 2 million lives each year, of which more than 250,000 are children. The theme of 2018 for the World AIDS Day campaign is Know Your Status. The 2017 statistics on HIV/AIDS in Nigeria makes for very gloomy reading. For instance, Nigeria has the second largest HIV epidemic in the world and one of the highest rates of new infection in sub-Saharan Africa. Many people living with HIV in Nigeria are unaware of their status. Nigeria continues to fall short of providing the recommended number of HIV testing and counseling sites. Low levels of access to antiretroviral treatment remains an issue for people living with HIV, meaning that there are still many HIV-related deaths in Nigeria. Punitive laws against homosexuality mean that men who have sex with men face difficulties accessing HIV services. Nigeria also has the fourth largest tuberculosis epidemic in the world, with HIV and TB co-infection now becoming an increasing concern for people living with HIV. It is estimated that around 2/3 of new HIV infections in Western Central Africa in 2017 occurred in Nigeria. Together with South Africa and Uganda, the country accounts for around half of all new HIV infections in sub-Saharan Africa every year. This is despite achieving a 5% reduction in new infections between 2010 and 2017. 6 states in Nigeria account for 41% of people living with HIV, including Kaduna, Akwa Ibom, Benue, Lagos, Oyo, and Kano. HIV prevalence is highest in Nigeria's southern state, known as the South-South Zone, and stands at 5.5%. It is lowest in the Southeast Zone, where there is a prevalence of 1.8%. There are higher rates of HIV in rural areas at 4%, than in urban ones at 3%. A message by the Executive Director of the United Nations Program on AIDS, Michelle Sidibe, reads, "On this World AIDS Day, UNAID is campaigning for people to know their HIV status and their viral load. In 2017, 9.4 million people were simply unaware that they were living with a potentially deadly but treatable disease. If people don't know their HIV status, people who are living with HIV can't start treatment, and people who are HIV negative can't get the knowledge and skills they need to keep that way. If people don't know their HIV status, they can't protect themselves, their families, their partners. If people living with HIV don't know their viral load, they won't be sure that the treatment is effective, protecting their health and stopping HIV transmission. Live life positively. Know your HIV status." Simply put, it will be difficult to add anything to that message.
Dr. Sonny Folorunsho Kuku is a consultant physician and endocrinologist by profession. Dr. Kuku has been Joint Chief Medical Director at the NACA hospitals, which he co-founded with 2 other specialist doctors in 1978. He was chairman of the Committee of Pro-Chancellors of State Universities. Dr. Kuku serves as a trustee of the National Postgraduate Medical College Nigeria and West African College of Physicians. Dr. Sonny Kuku received the first Distinguished Alumnus Award of University of Lagos. He also received the Ambassador of Goodwill Award from the city of Freetown. In addition to an honorary fellow of the College of Physicians of South Africa, he was conferred with the Office of the Order of the Federal Republic of Nigeria in 2003. He obtained a BSc degree in pathology and medical biochemistry in Lagos in 1969. Dr. Sonny Kuku welcome to the morning show.
Thank you.
It's a pleasure and a privilege to have you on the show this
My pleasure too.
Good morning, sir. Welcome.
Good morning.
As you have seen the data and the video we showed about HIV/AIDS, today is World AIDS Day, and the theme this year is Know Your Status. We've talked a little bit about some of the problems about knowing your status in Nigeria, and obviously the repercussions. What do you think is one of the biggest things that we have to overcome, or the services we have to provide, so that people can know their status?
Okay. There are basic rules and basic methods of combating infections. One is to make a diagnosis, then there's prevention, then there's contact tracing and treatment. The problem in Nigeria stems mainly from people not knowing their status. And of course, to know your status, you have to have a lot of testing areas all over the country. And that we don't just have enough of.
What does it require? Are testing areas expensive? Has the pricing of testing reduced over the years? Tell us more about these testing.
Yeah, the testing is expensive relatively. For middle class people, it's not much, but for the lower classes and the poorer people, it's quite expensive. And then in the past, the tests were not reliable. But now they're more reliable, and the things are now available in most laboratories. But okay, in the urban areas, there are laboratories, fine. But in most places, in the rural areas, you don't have laboratories, which is why the incidence is increasing in the rural areas than in urban areas. Now, of course, the prevention part of it is also very critical. And mostly abstinence and a one-partner relationship is the best way to do it. But that is strictly, naturally not possible for most people. And so that the prevention also uses mechanical methods like condoms and so on. And condoms also are not readily available to everybody. Yes.
Okay, so condoms are not readily available.
So when you're not preventing properly, the next line of treatment, of course, is treatment. That is a crucial part of prevention. In fact, in the developed countries, the reason why HIV infection rate has gone to where it is because there is treatment. And once you treat properly, the viral load just goes zilch to almost zero. Even at the highest point of viral load in a patient, the infectivity of HIV is not 100%. In fact, it's almost like 25%. That's the chance. If a person has a relationship with a person who has HIV, you don't get it every time.
If you're able to reduce the viral...
No, even in normal circumstances.
Oh, okay.
It's not 100%
that every
time it happens. So if you then can reduce it to zero, the chances go down by maybe 1,000%. So, in fact, in Europe and America, where these things are available, the infectivity rate becomes very, very little. We're not saying take treatment and go and be flippant.
Yes.
But we're saying that if the drugs are available, the infectivity rate will be much less. And that is where the government has failed. That's where the treatment is failing in Nigeria.
That's what I was just going to ask. Watching the SOT, and these numbers are quite alarming. And to see that Nigeria is the second highest, where this infection is, and talking about shared responsibility in a situation where, yes, the government has failed us, and they're not able to give us the help that we need. What steps can we take? What can be done to try to reduce these numbers?
All right. First of all, The fact that Nigeria is the second largest prevalence country, it's just got to do with the population.
Yes.
The percentage itself is average. I mean, it's even way below average of South Africa or Southern Africa at 3%. Those other areas, they go to 20% sometimes, 30%. But because Nigeria has a population of 200 million, 5% of 200 million is 10 million, you know. So if you look in absolute terms, Nigeria is contributing a lot to that problem.
And also, rates of new infections in those countries are not as high as new infections in Nigeria.
Yes, that's because those countries, the public health system is much better than here. Here we're just being saved by God, let's say, you know, because the exposure, people just don't even know what it's about. And fortunately, it's a very treatable disease now. I mean, if you had HIV, AIDS 20 years ago, it's death.
Yes.
But now, people can live forever with it. You know?
We're going to come back to the access of drugs and antiviral and the cost of that. But before we go to that, I just wanted to ask you, when she's saying that the shared responsibility, and you're saying there's a lack of knowledge on the public health sector, in that public health sector, for many years, NACA was the leading voice on HIV/AIDS in Nigeria. Yes. In the last few years, I mean, ever since the last director was transferred to the UN, and we unfortunately lost him, we have not heard or seen public campaigns like we did in the early 2000s. Where is that? What happened? What happened to NACA and this voice of public
I think the funding has just got much less. We've been having donor funding, and that is dwindling at a very fast rate.
Which also then, this goes to PEPFAR.
Yes,
so PEPFAR is funding that was provided during the Bush administration, and then dwindled a little bit during Obama's administration, and is about to dried up during Trump's administration.
That's right. So, unfortunately, most African countries depend on donor funding for even more major things. Nigeria is not as guilty, but Nigeria just does not know when to take off from where donors stop. So the funding from this is a governmental thing. It's not got to do with private sector. There are many things that people should help government with. This is one of the things that government has to take on, because it's social welfare, you know, and it's human capital. Because if you lose your human capital to AIDS, then you are in trouble. You know, so we just need to get government, both at local and state and federal government levels, to fund the money more, to fund it more. And I saw in the news a few days ago that we are now going to start producing antiretroviral drugs. This is something we should have done a long time ago. I mean, sometimes we obey laws that are not supposed to be obeyed. India started producing it against all patents long time ago at a very cheap rate. Because the major problem is the cost. The cost can be quite tremendous. But if you can produce it locally, the cost goes zilch to very, very low levels. So it's not even available to the common person, to the man, to the poor man. But right now, until we can take the bull by the horn, start producing the drugs ourselves, and government putting it as priority, even health insurance schemes, making it free, treatment free, we will not get to where we should get.
So let me just ask you a question, because I know that you said that it is government, it is a social responsibility. And you know, once again, I'm still a bit concerned about how we do our part, because do you really feel that it's more about people getting the treatment, and if there is availability, let's say government does provide these centers that are needed, or it's more about them being educated to even know to go and check your status. Because just from an employee point of view, I have had staff that have come to me and I've told them the first thing, you're dealing with my kids and you're dealing with my family, so it is important that you go get tested. And they go get tested and find out they do have HIV, and they are not aware, they don't even know what that means. And so then it comes to, okay, I have it, but what does that mean? And you're trying to educate them on what it is that they have and then how to stay safe at the same time. So sometimes I feel like, yes, while it might be the money to get the drugs in, they don't even know that they have. They don't even know what that even means. They have no understanding of it. So once again, if the government does provide these centers, do you feel, in your opinion, it is more about the education, or is it a joint education and just checking your status and knowing how to treat yourself?
Of course, education is the critical thing. And these people you're talking about
Yes.
know very little about anything. Basically, they hear about it, they know it exists, but they don't think it's something that will ever affect them. They don't understand the gravity. So part of prevention is, of course, education. Education. You go to some African countries and you can see it pasted everywhere.
Yes.
That doesn't really happen here. So the education, the status testing, and telling them the gravity of the problem is so critical. And I believe that if government takes their hands off the big things they go into and just restrict themselves to these welfare-based things that will affect 95% of the population, not the things that will affect 2%, and then they don't even do it well. All this will change.
I'd like to talk to you about your career, but before we go into that, I have done some work with HIV/AIDS NGOs, and I'm aware that NACA does have a helpline, toll-free 622, that's open to all Airtel and to select subscribers. And PEPFAR has just invested $90-something million into Nigeria in this war against AIDS. They're conducting a far-reaching survey, which we hope will now get more information, more research out. But NACA does need to, I think, do more in terms of enlightening the public. But so I want to talk to you about your illustrious career as an endocrinologist. Firstly, can we talk about what that means before I get into the question for our viewers?
All right, I was going to crack a joke, but I won't do so. Because some person was talking about endocrinologists, that is, people who are criminals. But in endocrinology, endocrine glands are glands that produce hormones. So an endocrinologist is somebody who works in the field of hormones and endocrine glands. And hormones are everywhere. In fact, the whole body control is hormones and nerves. So the major hormones are the ones we all know, growth hormones and sex hormones and insulin and thyroid and all. But there are a lot of other hormones. And so that field is basically a very major area. And what the most common hormone disease is diabetes, that everybody knows. And then the thyroid diseases, everybody knows that too, but there are a lot of other hormone-related diseases, which is our own secret.
So, but you've had this glowing career. Many of us have followed you. Echo Hospital was such a landmark. That was the first private hospital to be traded on the Nigerian Stock Exchange.
Correct.
You've been a medical doctor dedicated. But now, today, you have the Minister for Health advising our doctors to go into tailoring, to go into agriculture. Do you see in our current climate young doctors following your footsteps, being able to achieve the feats that you did? In view of the constant strikes that we have right now, Luth is on strike. What can young doctors today do to try and aspire to walk in your footsteps, sir?
Well, I sincerely hope the minister was misquoted about going to agriculture, because we have our doctor ratio is so low.
It's one of the lowest in the world.
And It was probably just misquoted.
I like the benefit of the doubt, but that's okay. That's okay.
In terms of our doctors, the problem really starts from the day they qualify. They don't get house jobs. They don't go that very critical 1 year of the pre-licensing. They don't get it, so the frustration starts from there. And it's not a difficult thing to solve because all you need to do is give them 1 more year in medical school. It may be unpaid, but at least they use it as a practical year. Again, this is something we've advocated for such a long time. But again, the authorities just don't understand the gravity of that because without it, you cannot be a doctor. You cannot really practice as a professional. So after that, then I have a career problem. Like we said, there's a dearth of doctors, but there's also a dearth of positions for them to work. And they get frustrated. And then the qualification to get into medical school is the highest, the cutoff point, by far the highest. And people who then do a shortcut course suddenly get good jobs. So the doctors get frustrated. That's why some of them are going to carpentry and furniture making and all.
And migrating. I mean, we have the brain drain.
I was even going to go to that because then they all find a way to circumvent visas and go abroad. The developed countries are paying lip service to the fact that they are saturated and all, but they are actually attracting them.
They are attracting them?
Yeah, because when they all get there, they still get positions and they stay there. The postgraduate medical colleges in Nigeria, the national and the West African, have done a lot to curb that. But one had hoped that when people are trained as specialists, they then would have a lot of confidence to stay back. But when they then finish, they don't get the right type of jobs, and then they don't have the right type of equipment. Because if you're a specialist, it's like a barber not having scissors. You know? So then they get frustrated. And then they find their way out of the country again and go and do the exams all over. And many of them end up in rural areas in those countries. So it's the frustration. And people, I think job satisfaction has got to do with salaries, but even more with the availability of the tools to do your job. That part of it is causing even more problem.
Than just the salary. So there's sometimes, do you feel that we overemphasize the salary issue and de-emphasize the fact that these are passionate people that have gone to study and they're actually not able to
They're not able to do what they're supposed to do.
Medicine is a calling. Like for you, it was your lifetime dream, sir.
Yes, that's right. And also, when you go into medicine, you don't go into it hoping to be very wealthy or very rich, because you cannot be rich. You don't even have time to spend the money anyway, you know. But people go into it because some people go into it hoping that it will make them rich. Then they get distracted and they don't do it well. So there is a calling to it. I mean, you just have to love it. You just have to enjoy it, because sometimes it can be very, very, very frustrating to see somebody you treated for a couple of days or months just pass on suddenly. You know, I remember as a house officer, the first patient I saw died.
Oh wow!
As an emergency, that is enough to throw a lot of people off.
Yes.
But if you're strong and you know you do what you're supposed to do, you get into it. But it's a calling that is so satisfying, because okay, you get occasional people who pass on, but 99% of people who treat get well. Yes. And then you see them 10 years later and they say, "You treated me and I'm alive." I said, "I know you're alive because."
When you look at endocrinology and the study of it in our universities, one of the biggest issues that endocrinologists deal with is diabetes. Nigeria has a very high diabetic population.
Yes.
Tell us about that and the treatment, and how many endocrinologists are we actually training every year to deal with this issue?
All right. In the 50s, the research that was done said there was no diabetes in Nigeria.
That there was none.
No. That was 90% true. But 10% was because there was no contact, no testing. This the same thing for the HIV.
Yes.
There were no, the diagnosis was not, people were not coming out for diagnosis. But it has increased. And it has increased mainly because of urbanization, because of change of lifestyle and diet. And you can even see it as you move from rural areas to the urban areas, the prevalence increases. These refined foods and so on, and lack of exercise, you know, they've just done something to everybody. And it's not just Nigeria. In the United States, for instance, the Indians, the native Indians, never had diabetes. And they were nice and trim. You could, I don't know if you watch those Indian films,
Yes.
West Indian films, those American Indian
The old
films.
Westerns.
Old Westerns, yeah. Strong people. But now, if you go to reservations, they are very fat. Yeah. And that's, if you take a Chinese living in China and a Chinese living in New York, the prevalence of diabetes is more. So there is no doubt at all that it's a lifestyle change. Diet, lifestyle, and so on. So we're having that problem, and it's becoming an epidemic in Nigeria. It's a very, very serious thing.
What are we eating that's causing this? Like, what type of food?
It's refined foods.
We eat a lot of refined food in
You do.
We do.
You do. Bread is bread.
Okay, bread. Okay.
Everything is refined. You take sugar. Sugar is a
All the
refined
soft
form of
drinks.
carbohydrate.
All the soft drinks. Okay.
Yeah. And a lot more oil. We're eating in a ratio that was not designed by nature.
Yeah.
In fact, what you eat is really what you should eat according to nature, according to the way God provided. God provided carbohydrates as the largest amount of food. So you should actually, I'm not saying you should be a vegetarian, but you should eat mainly plants and fruits and because that is abundant. In fact, the bigger the animal is, the more herbivorous they are. You know, if you see an elephant cannot afford to start eating animals because they eat up all the animals. So God made it in such a way that they are plant eaters. Then the next common food is oil. So you have carbohydrates, then oil. Then the animal. To get to eat animals, you have to kill. You have to have a weapon. You know, so that's the way nature does it. So what it means that most of your food should be plant-based food. Then it's little amount of oil and even smaller amounts of proteins. But you should have proteins. You must have it. All these vegetarian diets, like take India, which is 90% vegetarian, their life expectancy is not higher than countries that have that eat. Yeah. So nature has given us that opportunity. And then exercise. Remember, when I was younger, I used to walk to school. You walk 10 miles, 5 miles to school. But everybody goes in cars now. That's why even diabetes is getting common in children.
Yes.
The type of diabetes that was in children was the type 1, which is the one where insulin is really not there at all. But now children are getting type 2,
Yes.
which is what you get after 40. So we're really facing a very bad epidemic. So most of it, again, is education and prevention. Education and prevention. Because you don't want to get to the point where you need to take drugs for diabetes because they are very expensive. And again, they're not made freely available. So the principle of managing infectious diseases is the same principle of managing non-communicable disease.
When you look at, I want to come back to HIV/AIDS because it is World AIDS Day, and you look at the video we watched earlier about the prevalence, and actually the prevalence among men having sex with men. The video said that there are 23% of the cases of HIV in Nigeria is among men having men. And a lot of that is because they're not finding out their status. A lot of that is stigmatization, criminalization. How can Nigeria, even though we've criminalized homosexuality, how can we still, because this population is still a danger and they're at risk. How do we manage this population and get them the awareness, the help they need? What advice do you have?
All right. I'll be very careful with this because nature does not. One of the most important things about nature is that it wants to procreate, to move. So, sex between men and men is totally against nature.
Yes.
So, but for the fact that these people also now infect other people, one would just tell them to just keep doing it and suffer the problems of Sodom and Gomorrah. But that's not realistic because the man who is doing it may be bisexual, so he goes home and gives it to his girlfriend or his wife. I think, first of all, we should educate men not to have sex with men. Because one of the reasons why they get it more often is that they tear the coverings of the rectum. And once in fact, infectivity of HIV depends on the integrity of the skin or the mucous membrane. That's why people who have infections get it faster than those, because there must be blood mixture. Okay? So when they do that, they tear off the mucosa in the rectum, so they get more infected. So it's an unnatural place to have intercourse, just simply put. Then they need to be educated themselves that they should also use condoms. And they should also, like you said, stigmatization drives them under the table. So they should be encouraged to come out and get treated and all. But it's amazing that it's getting commoner and commoner in Nigeria. It is really...
That's the reality.
It is really, really... But a lot of it is also due to the fact that people are now doing it for money. They are prostituting themselves. Many of the men who are doing it are not naturally gay or homosexuals. They're just doing it as a sex workers. It's a very delicate area. I think that as much as possible, there should be enough legislation to discourage, so that those people who are doing it for this type of thing will not do it. But those who have that natural attraction for the same sex, you cannot eliminate that, because even in animals it occurs. So there are some centers in the brain that have just been developed in a different way. So they do exist. So we cannot say just ban all of them. But those who are not naturally that way, who have developed the interest in it, people who do it for rituals, for instance. Some people do it because they think it will make them wealthier, they live longer and all that. Those ones are the ones that we need to really try and get off back. But it's a very serious situation. Unfortunately, I'm not an infectious diseases person. I'm more of a non-communicable disease. Endocrinology is about non-communicable diseases. And if I can distract a little, non-communicable diseases have overtaken communicable diseases in most of in the developed world, definitely. And in Africa, is rapidly doing so. Because Africans are living longer. Once you can escape the first 5 years of your life, can go beyond that, the chances of getting to 60, 70, 80 are very high. And once you start getting to 40, the organs start degenerating. because most of these diseases are diseases of degenerating organs, the kidneys, the pancreas, and so on. We must start paying the same attention as we are paying to AIDS, to these diseases. We must, it is critical, because the infectious diseases, malaria costs a few pennies to treat. But if you get a kidney problem, can bankrupt the person.
Yes, that is true.
And can bankrupt government itself. And then the poor people get poorer because they cannot work, and the resources of the country that could be used for other things are used to treat people.
Please tell us about your Sonny Kuku Foundation, sir.
All right, that's a foundation that I started. It does two things. One is about diabetes. The other is about sickle cell. There is no relationship, straight relationship between diabetes and sickle cell anyway. But I'll tell my story again. And I think telling that story would help. My mother had seven of us. And only I survived of it. There were two people before me and the rest after me. When I got to medical school was when I knew it was sickle cell disease. Because we were doing physiology and we were testing things. So the sickle cell also needs people to check themselves before they get married. Because that's the best way to prevent sicklers. And Nigeria has the highest pool of sicklers in the world, of people who have traits, because the gene is 25% prevalent. So 1 in 4 people have a trait in Nigeria. So you can imagine them meeting. So if there is no counseling, then you have a problem. So based on that was why that foundation does that. So that's really an emotional thing. And what we do there is enable people, we train, we enable people to get equipment for prenatal testing and so on. And so that was that. Then the diabetes, of course, is my passion for endocrinology. And also the fact that I know that, believe me, the incidence is rising, like I said, in 1950, when it was supposed to be zero, quote unquote, to now it can go as high as 20%, 25% in older people. Because it increases with age. And it's very, very, you can virtually prevent it, getting it at all, by starting life with the right kind of diet, the right type of lifestyle, and the proper approach to exercise and so on. So we also deal with that there. And I must say we've achieved quite a bit there, quietly. One of the problems I had was we were going to set up diabetic clinics in some government rural things, and we were stopped. And amazingly, the reason was that we were making the government look bad, that the government cannot do it themselves. You know.
But it's the reality. I mean, every week we have people on this show that talk about health and some of the challenges we have with our health system. I wanted to ask you a question about sickle cell because recently we've lost someone in the industry there was also a sickler. A couple of weeks ago, a Chinese doctor altered the genetic makeup of children before they were born in the womb. And the reason why is because of HIV/AIDS, so to prevent them from getting HIV/AIDS. So this genetic DNA was done.
The
chromosome was done. With sickle cell and the type of prevalence we have in Nigeria, what can be done? There's counseling, but from a genetic perspective, what are the opportunities? What does the future hold when it comes to genetic alterations with sickle cell?
All right, let me say something that I always love to say. If sickle cell disease affected Caucasians.
Yes.
It probably would have been eliminated a long time ago.
Would have been cured by now.
Yeah, because there are more people with sickle cell disease than AIDS anyway.
Yes.
But the developed countries, because it will affect them, have gone into it. Now, the ultimate treatment, apart from prevention, like I said, is bone marrow transplantation. And we don't have a center in Nigeria. In fact, the Sickle Cell Foundation is the one that's about to build the first one. And in a few months, it will come up. We should have maybe 100 centers doing that. Because once you do that, that's a cure.
So bone marrow.
Because right now, bone marrow is the only way.
That is the only cure.
That's a cure. Then coming back to the genetic manipulations, of course, that is the ultimate.
Yes.
And it could have occurred if, like I said, the approach to sickle cell was the same approach as to AIDS, or if we have the centers in Nigeria that are devoted to people-centric systems. Because we should have here the best doctors for sickle cell. In fact, people from the United States should be coming to us here. We should have the best systems, but we just don't have. It's just as bad as that. All we do is just give them anti-malarials and folic acid and some antibiotics from time. Now, this drug called hydroxyurea is just beginning to be common here. This has been used for tens of years in the US. Yeah. So our health system really is an emergency, just like our education system. What it really means is that the human capital system here is really faulty. The development is really, really faulty. So there is so much opportunity to get the sickle cell out of our system. And sickle cell itself is a protective mechanism by nature, because if you look at the map of where you have sickle cell, which is West Africa, then Mediterranean, South Africa, it's the same malaria belt. So God has helped us, but it has now become a problem, and heaven helps those who help themselves. So there are so many areas that government can excel. This, like I said, I'm mentioning government because these are areas, it's a governmental thing. But there are so many things that we can do that the government doesn't have to be brought in at all. But those areas that government needs to institute, because that kind of institute needs to be started by government.
Yes.
Then slowly the private people will take over.
To fund and take over.
Yes.
Well, we hope they let you build your centers.
Yes.
Like I said before, the major function of government is law and order. That is to put into place enabling laws to allow people to build centers. But we're not doing that. Social welfare, law and order, and security. That's what government is for. All these other things that government does is just not in their purview at all. But these are the political discussions.
It can always, everything in Nigerians comes. I have to say, it's been such an honor to have you on the show.
No, it's my pleasure.
Thank you so much for coming, sir.
Good.
It's time now for a short break. When we return, the Managing Director and CEO of Roach Investment and Manufacturing Limited, Dr. Teju Bolujoko, will be joining us in the studio to speak on manufacturing and the challenges of infrastructure in Nigeria. So stay with us.